What's up, everybody? Dr. Rossi, board certified psychiatrist here, ready to bring you another exciting topic in psychiatry and mental health. Now, before I do, if you're not a member of this community, please consider subscribing to the channel. It really helps me to know that this information is valuable to you and that you're learning something that you can apply to your daily life. Now, if you're a returning viewer, thank you so much for all the love and support. It does mean the world to me. Now, today's topic is going to be an exciting one because if you solve this problem, you solve one of the great issues in all of psychiatry and mental health. And that is, why does someone who's in a proper evidence-based treatment, say on an evidence-based medication, seeing a therapist, doing all of the right things, why does this individual still feel depressed and not have remission of their depressive symptoms? This is a big deal because we know from the STAR-D trial, for example, that only about 1/3 of people reach remission with their first antidepressant treatment, and that only about 50% of individuals have a response to treatment, which is defined as a 50% reduction in symptoms. So we know people don't get all that much better, or at least not to the degree we would like. And this discussion is designed to primarily focus on what are those factors? What are the symptoms of depression that indicate a possible poor response to medication treatment, or in general, a poor response to depression treatment overall, whether that be psychotherapy or medication management. So we want to go over what are the factors that prevent people with depression from getting better. So more on that in the next section. Let's answer the question, what causes functional impairment in major depression? So what causes functional impairment in major depression? Now, there's a few things we can say first. I've said it in the previous session, but I'll say it again. From the STAR-D study, we know that only about 50% of patients have any response to the initial antidepressant treatment, and that only about 1/3 of those individuals achieve remission. Now, an important question here again is why? What are the symptoms that predict such a poor response? And why aren't more people getting better? So, contrary to popular belief, the depression medications, the so-called antidepressants, actually do a pretty good job of treating certain symptoms of depression. So let's take some examples. For example, neurovegetative symptoms, these are the things we think about commonly when we're looking at the SIGI CAPS mnemonic, right? We're looking at sleep, interest, guilt, energy, concentration, right, appetite, etc. And the things like sleep and appetite actually improve when somebody is treated with antidepressant medication. These things get better, and they get better, relatively quickly. However, the important point here is that the symptoms that often remain the longest in major depression, the ones that are the most debilitating, don't end up getting treated by traditional antidepressants or other interventions. That's the issue. The issue is that the things that really lead to disability and poor psychosocial function are not really well treated by medication. So let's take a look at those two. There's two specific ones that I want to focus on in this video, specifically anhedonia, which can also be thought of as a loss of interest in previously pleasurable activities. So things I used to enjoy, I no longer feel that same joy and pleasure doing them, right? So anhedonia is the first one. And the second one is the cognitive dysfunction associated with depression. So cognitive impairment and concentration problems are very significant predictors of poor response to depression treatment. So these cognitive symptoms can be things such as trouble concentrating, difficulty planning or making decisions, and also poor attention that leads to dysfunction at home and work. And when we're dysfunctional at home and work, obviously our depression is going to continue because we don't feel like we're getting any better. How about cognitive symptoms and impairment at work? This is very, very important, right? I said that the two things that are most important or consistently found in poor response to antidepressant treatment or treatment in general is going to be anhedonia or loss of interest and cognitive dysfunction. Now, obviously, we all need to work. I need to work, you need to work, we all need to work in order to live because that's the society and that's the way things are, unfortunately, right? Or fortunately, depending on how you view things. Now, we know that depression is a leading cause of disability and poor work performance worldwide. So this is not exclusive in the United States, for example, or in the UK. This is all throughout the world. We see poor work performance and disability as a result of poorly treated or untreated depression. Now, what we know from this study that I'm going to talk about here is that subjective measures of cognitive dysfunction were better predictors of workplace performance than total depression severity. Now, what I'm saying here is quite complex, right? That's a lot to kind of take in, but let's put it in perspective. What this is telling us is that someone with more severe overall depression scores, so say somebody that's doing their Hamilton Depression Inventory, right, scores very highly on it, somebody with high or more severe overall depression scores may actually perform better at work if they don't perceive any cognitive dysfunction, right? They don't perceive a cognitive dysfunction associated with their depression. So they can perform better. So that subjective sense that of a perceived cognitive dysfunction is a strong predictor of workplace performance and overall continued depression in those individuals. Now, this is one of the possible reasons for a lack of improvement, as many of the treatments that we use in psychiatry and even in therapy, honestly, do not address cognitive symptoms. Cognitive symptoms are often very difficult to treat. So we need to put a little more emphasis and focus on how to improve cognition in individuals who are experiencing depressive episodes. So I'm just going to say it, guys. Anhedonia, or loss of interest, it makes everything worse in depression and depression treatment, of course, right? So possibly the most debilitating symptom aside from cognitive dysfunction associated with depression is going to be anhedonia, or loss of interest. Now, again, I said I think of anhedonia as a decrease or loss of interest in previously pleasurable activities. So things I used to like to do as a hobby, say I used to like weightlifting, for example, I no longer derive any interest. I cannot get myself motivated to do it. I don't enjoy it. When I go out there, I'm just going through the motions. I'm not really improving or performing well. So a loss of interest in previously pleasurable activities. Now, we know that anhedonia is a very strong predictor of poor antidepressant outcomes. So if loss of interest is present, which it usually is in depression, right? People are depressed, they're going to have a loss of interest. It's generally a poor predictor of antidepressant outcomes. So people have worse outcomes when they don't have any interest in the things they enjoy doing. This would make anhedonia a primary target, right, for treatment, and would otherwise improve outcomes in depression. So we want to really focus on anhedonia as an important primary target here because it really does lead to poor outcomes. We have additional evidence that also indicates how important anhedonia is for things like psychosocial function. So my ability to just function in daily life can be severely impaired by depression, and specifically the symptom of anhedonia. Functional improvement, when we look at this study, was strongly associated with improvement in anhedonia. So basically, there's a really strong correlation between somebody's perceived improvement in their loss of interest, right? They become interested in those pleasurable activities again. Their depression seems to get better. The improvement of anhedonia actually had a larger effect on psychosocial function than overall symptomatic response. So this again goes to show you how important some of these symptoms can be and how these symptoms are largely ones that are difficult to target with medication intervention, unfortunately. Emotional blunting affects treatment outcomes. This is important to note as well because emotional blunting is a common side effect of the monoamine antidepressants that we are prescribing. So we have to be mindful that emotional blunting can cause problems. And the way I think about this in my life, in my clinical practice, is that while people do not want to be depressed, they also don't want to be emotionally numb. Right? They don't want to feel emotionally dull, like they can't experience pleasure, they can't experience sadness, they just feel like blah, right? Nobody wants to feel blah. Unfortunately, we know that that emotional blunting, rather, is reported in up to 50% of people taking antidepressants. So about half of people taking these medications have reported a feeling of emotional blunting, which is concerning. Now, this appears to be common for all of the monoamine antidepressants. So you might think some antidepressants are better than others, and you'd be correct about that. With bupropion, also known as Wellbutrin, being the one with the lowest risk of emotional blunting, but it still has a risk for emotional blunting, and people did report emotional blunting on bupropion. So it's important to note that. It's also important to note that emotional blunting cannot be accounted for exclusively as a side effect of treatment. Most of the time, emotional blunting is also present as a symptom of major depressive episode as well. So it's multifactorial, right? While antidepressants have been known to worsen emotional blunting, there's also emotional blunting that occurs as a result of depressive episodes themselves. And the point here still remains the same, despite that information, that emotional blunting results in poor quality of remission. So when somebody has remission per se, right? Let's say remission being defined as complete loss of all symptoms, they're asymptomatic, they feel good, right? We're talking about remission here. If they're emotionally blunted as a result of the medication that led to remission, it leads to a poor quality of that remission. The person not really feeling like this is truly remission, so to speak. Doctors are too medically oriented. So what do I mean by this? This is an important point too. The world of psychiatry is very different than other medical specialties. There's some medical specialties like cardiology, for example, where if you're just medically focused, you're going to be fine, right? You know, the heart is a pump, it's based on physics, the functioning of it is very well defined, and you know how to do things to improve its efficiency, for example, right? So other medical specialties can be really, really medically oriented. However, psychiatry is different. Psychiatry is really more of an art that's rooted in science. We obviously want scientific fact to back up the things that we're doing, but we understand that there's a lot of art that goes into getting somebody with depression, for example, better. Now, if you try to take this approach, right, and there are people that do this, and I often think it's the people who have never had any shit happen in their life. It's important that you've had some failures. It's important that you know what it's like to suffer a little bit, that you've had some difficulty in your life, that maybe your parents weren't able to make ends meet from time to time, right? Because that gives you a different perspective. It gives you a perspective that is very relatable to a psychiatric patient who is often used to those same kind of circumstances. So that's a little bit of an aside, but getting back to the point here, if I am just some, person who's had a great life, everything's been perfect for me, and I think I'm going to take this really scientific approach to treating your mental health conditions, then I'm going to be sadly mistaken, and I'm likely not going to help anyone, right? There's a risk that I'm going to be a shitty psychiatrist if I just take a scientific approach to everything that I do. Okay, fair enough, right? So when patients and physicians are asked to rank symptoms of depression, right, in terms of importance, we see that the lists don't match up at all. So that's kind of frightening, right? We're seeing that patients have a very different focus on what would lead to restoration of positive affect compared to what your psychiatrist or doctor is thinking. Even primary care doctors could be lumped into this example, right? Because they're prescribing antidepressants quite often. So when we look at the patient's things that they rank as the top factors that would lead to restoration of positive affect and remission of depression, they cite things like meaning and purpose in their life, right? That's a big one. I want to feel like I'm contributing to the world and to society in a meaningful way, and that my life and my work matters, right? So meaning and purpose in your life. Another one is enjoyment in life. I want to be able to take some pleasure in the things that I'm doing, whether that be my work or leisure activities. I want to feel good doing them. The third one that patients listed was that they want to have satisfaction with themselves. So I would say that this could be likened to self-esteem. They want to feel like they're, good about myself. I feel confident in my body. I feel confident in my ability to speak. I feel confident in my ability to interact with other people. So they want to have a stable sense of self, right? So those are the things that are very, very important to patients. And clearly, what should stand out to you guys as the viewer is that all of these things are not going to be treated by medication, right? That should be obvious to you. Medications do not provide meaning and purpose in your life. Medications will not make your life more enjoyable necessarily, and you will not have increased satisfaction or self-esteem because you take antidepressant medication. So clearly there's a disconnect there. Now, when we ask our doctors, right, to rank the symptoms in order of what they feel are most important, they rank depressed mood at the top. Well, yeah, I mean, I could see that. Depressed mood, they also talk about hopelessness and anhedonia in their top three. So depressed mood, hopelessness, anhedonia, top three for physicians. But what we see here is that these are, first of all, symptoms that are a little bit better addressed by medication. We could argue maybe hopelessness and anhedonia are kind of difficult to treat with medication, but let's just say that in general, the physician's rating scales are targeting things that medications might be able to help with, right? Whereas the patient is looking at, things for meaning and purpose in life, self-esteem, feeling good about things, right? These are difficult to treat with medications, and that is the main point, is that not only do we have a disconnect between what the physician thinks is important and what the patient thinks is important, we have treatments that don't really help with the things that patients feel are most important. The effect of loneliness on health outcomes. So this is not just mental health outcomes we're talking about here, we're also talking about physical health. Right? Loneliness is a problem, and I've talked about it before. It continues to be a major concern in the modern world, and we are the most connected that we've ever been in any time in history, but yet people still feel disconnected, right? And that's because we're largely connected electronically, like we're doing right here. We're connecting through video, through social media, through the internet, but we're not really connecting with people in our personal lives. And this is a huge problem, and people continue to feel lonely despite having access to this whole world in the palm of your hand with your cell phone or through the internet on your computer. Now, this is an existential crisis, right, for all of us. And I haven't heard many good solutions for how to fix this. I have not heard many people come up with ways that we're going to combat this problem, but clearly it's not going to be combated by medication, right? Time and time again, we go back to those same things, the internet, social media, that make us feel disconnected anyway, and we're let down. We go back to connect that way, and then we're let down by this process because it doesn't work, right? It doesn't make us feel any better. So not only is this going to be emotionally taxing on people, it's also affecting their physical health, and this study goes to show that. Here's yet another example of something that's very important in the treatment of depression, right? Helping people feel more connected and less lonely, that we cannot fix with medication. So again, another reason why people with depression may remain depressed despite our best efforts with psychotherapy and medication management. So in conclusion, what does this all mean? Should we stop attempting to treat depression altogether, throw our hands up and say, hey, well, people are depressed, whatever, it's the leading cause of disability worldwide, it's causing all kinds of workplace dysfunction, but who cares, right? Because we don't have any meaningful treatment that's going to help these individuals. I don't really think that's what we should be saying. For me, these findings tell me a couple of things. Number one, I, as a doctor, should be screening more carefully for the specific things that lead to poor outcome. I should be really focused on the cognitive effects as well as the loss of interest that people are experiencing, and I should also be open to the ideas that loneliness can play a role here, and that the medications can cause things like emotional blunting that may be affecting the person's remission as well. So I need to be open, screening, looking for these things, and then trying to address them. Which comes to our next point, right? We need to improve our psychosocial treatments because clearly, like I said, medication's not going to give you meaning and purpose in your life. It's not going to give you more self-esteem. And it's certainly not going to give you necessarily more joy and pleasure in your life. Those are things that you have to come up with as an individual. What are the things that are meaningful to me? What would make me happy? How would I feel more connected with other people? They're individual questions, and it's going to be different for everybody you encounter. So we also need to understand the limitations of medications here. That's another good point of this whole talk, is that medications have a place. They do work well for some of the neurovegetative symptoms of depression. It just so happens that they aren't the ones that people cite as the most important in their lives. So the unfortunate part in the end of all of this is that while medications can be helpful, psychotherapy can be helpful, the things that are most important to patients are not well addressed by monoamine antidepressants. So I'm going to hold it there, guys. I'd love to hear your questions and comments below. If you have them, please drop them. I love to see them, love to answer them as best I can. And again, if you have not subscribed to the channel yet and you watch this video all the way through, I would definitely encourage you to do so, as we'll have a part 2 to this video where we're going to discuss what the augmentation strategies are to address some of these problems. So until next time, take care, guys.